Good afternoon, everyone. My name is Sam Takvorian. I'm from the University of Pennsylvania. Thank you, Larry and Lisa, for the invitation today to discuss the prospects of digital health and artificial intelligence in supporting our cancer care force. It occurred to me this morning as we were discussing high-performing teams that really what I'm being asked to pontificate on, I suppose, is whether or not the mobile phone that we're all carrying and looking at right now and checking our email on, whether that can not only augment the patient voice and bring their voice to the table and be part of that conversation, but also whether or not the phone itself can be sort of part of that team, if you will. I have no relevant financial relationships to disclose, but I did want to point out that the University of Pennsylvania, my employer, may receive royalties in connection with the product or platform that I will be discussing. Much has been said already today about the changing oncology care delivery landscape, but I would like to sort of reemphasize 2 points. The first being that the accelerated use of oral anti-cancer medicines is on the rise and is contributing to a phenomenon whereby our patients are spending less time in the infusion visit, less time in the office visit, and more time at home and at work. And that's great for our patients, but it also does mean that they're shouldering a greater responsibility for side effect monitoring, for symptom management, and for medication adherence. And yet without concomitant delivery care structures to help support them in that endeavor, or for that matter, to help support all of us in helping to support them in that endeavor. And then second, Dr. Levy and others have mentioned the burgeoning evidence base for the routine collection of electronic patient-reported outcomes. I think it's exciting. The evidence base is exciting, but I think there's still a significant implementation gap. And I think that optimal strategies for implementing electronic patient-reported outcomes are still just becoming understood now. And so what I would say is that at Penn a couple of years ago, we began really thinking about these two different phenomena, the fact that our patients are frequently beyond or out of our reach and are no longer captive in infusion suites. And at the same time, there's increasing evidence to support an augmented patient voice in clinical decision-making. And we asked ourselves the question, could we develop patient-targeted strategies that leverage digital health and artificial intelligence to help bridge this gap? We conducted contextual inquiry in which we interviewed patients admitted to our solid oncology service for poorly controlled symptoms, and we learned from our patients that they wanted to be engaged outside of office visits, that they were accepting of using their mobile phones as a method of engagement, and specifically that they preferred text messaging to other modalities of communication, including apps and telephone calls. And so from this learning and in partnership with an industry partner, a company called Patiently, we developed a new care paradigm, the tenets of which are as follows. First, real-time conversational engagement of patients via text messaging and with built-in motivational feedback. Second, patient-targeted use of artificial intelligence and machine learning to support specifically symptom management and medication adherence. And third, seamless electronic health record integration from the beginning that allows for longitudinal monitoring and triggered provider team alerts. The result of this collaboration was a platform, or is a platform, that we call Penny. And I'm just going to highlight through the following images some of the key features of this platform. So Penny is first and foremost a virtual care team member, available at all times to patients who are navigating the complexities of oral anti-cancer regimens. Natural language processing capabilities allows Penny to have a conversational dialogue with the patient in real time. So you can see pictured here, Penny introduces herself, says hi to the patient. I'm Penny, you're gonna start your regimen, which consists of capecitabine and temozolomide, and asks at the end of that first text, do you have any questions? Julie says, no, I think I'm clear. Okay, great, I'll reach out in the morning. You can see how it's a natural dialogue, and Penny mimics a human feel. Next, Penny provides step-by-step personalized guidance to support adherence behavior, and specifically embedded in the text chain are clear real-time dosing instructions. So for this particular regimen, there are complexities to the regimen with different pill sizes, multiple daily dosing, etc. And you can see that this is visually very clear for the patient. And then finally, an adaptive rules engine enables monitoring and in some cases automated responses to symptoms that are reported by patients. This is a key feature of the platform that we have developed. And it rests in some sense, I think, on the literature supporting routine collection of patient-reported outcomes. A patient who develops a symptom can engage the platform using free text, can text the platform describing their symptom, and Penny will iterate with the patient until that symptom is understood in a lexicon that's familiar to us as providers. So essentially grading the symptoms along parameters that are very similar to the CTCAE that I'm sure many of you are familiar with. Once it's there, if the symptoms are low grade, self-management advice that stems from algorithmic branch logic, essentially pathways that we've created at Penn, can be reflected to the patient. Or if there are higher grade symptoms, that can then be triaged to the appropriate person on the provider team. In preliminary testing, studied among patients with neuroendocrine tumors on capecitabine and temozolomide, a particularly complex oral chemotherapy regimen, 11 patients were approached, 10 agreed to participate, and underwent a 4-month, essentially pilot project. Across the board, there was very high participant satisfaction. The platform itself had high fidelity and reliability with accurate grading and triage of side effects. You can see here, compared to historical controls, that patients undergoing the intervention reported daily adherence of 98% compared to 80%. There was significantly reduced call volume over the 4-month study period, whereas historical and matched controls reported 11 calls over that period. Penny patients had closer to an average of 3 calls over the study period. And upwards of 80% of the call volume were able to be effectively handled by Penny. And then finally, this is somewhat anecdotal, but patients reported during qualitative interviews that 3 emergency room visits were avoided. This is just a quote: "When you think you're in the moment feeling that sick and you aren't thinking straight, Penny is that straight thinker we needed at those times." That's right from a patient's mouth. So my time is up, but I just wanted to say that these are early days. We've only done preliminary testing, and we have ongoing phase 1 study and plans hopefully for a randomized phase 2 study. But in early testing, Penny was feasible and acceptable to patients, and substantially reduced call volume and improved provider triage, we think, demonstrate the potential for this kind of technology to support the cancer care workforce. Thank you.